good evening and many thanks to DMO for inviting me to talk on an area I'm incredibly passionate about. What I'm hoping to achieve through this presentation is the importance of helping the Ehlers Danlos, hypermobile Ehlers Danlos patient as a multidisciplinary team. So during the presentation, what I'm going to try and take you through is basically the journey that we took into recognising the hypermobile Ehlers Danlos patient, why we built Physiocure into a multidisciplinary team in the treatment of hypermobile Ehlers Danlos, the benefits of a practice working alongside DM Orthotics for the HEDS patient. And I've got a couple of case studies of HEDS patients from the physiotherapy and DMO perspective. So Physiocure. Well, Physiocure, as we're talking about tonight, is a multidisciplinary team. Me and my business partner, Louise Grant, established Physiocure in 2000. We're based in North Leeds, United Kingdom, and we treat a wide variety of musculoskeletal issues. And my business partner, Louise, has actually developed a specialist hip centre called Hip Physiocure. Our ethos: the holistic management of all our patients. So how did our journey into hypermobile Ehlers Danlos start in hypermobility spectrum disorder? Well, what was going on is, as Louise was developing her work with the hips, I was sort of developing my work with specialising in shoulders. And what was starting to happen and what we noticed was Louise was often coming and knocking on my door, and I was often going and knocking on Louise's door. Louise was saying to me, "Anna, some of my hips have got problems going on with their shoulders." And I was like, "Oh God, that's strange, because I've got lots of my shoulders have got problems with their hips as well." And although we were addressing the issues holistically at that time, as in we were looking at all of their strength, their patterning, the whole body movements, there was just still something that was not quite right. And I am actually going to go into a bit of a slide in a moment about our work with the surgeons. But what we were also starting to know is, because of this work we have with our surgeons, we were noticing that some of these quite complex cases were also having poor outcomes, and we started to think there must be a link. Signs started to occur. So before our awareness of hypermobile Ehlers Danlos, these were the type of things we were seeing. Louise was seeing her hips, I was seeing my shoulders. Don't get me wrong, we were treating the person as holistically, but we weren't quite looking at the bigger picture. So now when patients come in to see me, I am looking at their skin extensibility, I'm looking for atrophic scarring, I'm looking for pyogenic papules, I'm looking for dental overcrowding, bluish sclera, because all of these things are going to connect. And what we must remember with that word connection is, if you can't connect the issues, you have to think tissues. So how did we meet DMO? So Louise and I started to become quite passionate about this area, as I say, and we started to need to get more and more knowledge on it. So we started to go off on courses and conferences. And in 2018, we travelled to Ghent and attended the Ehlers Danlos Society's conference. And that's where we met DMO. At the time, I was having quite a lot of issues with my thoracic spine, mid-spine, and I also do suffer with my shoulders at times. And I just said to Louise, "Do you know what? I'm going to try on one of the shoulder orthoses." So I went over to the table. Patricia was there, asked to try it on, and instantly I could feel a difference. Now, I go to the gym, I do train, I try and keep fit. And even with all of that, I still could feel this difference from wearing the orthotics. So I immediately went back to Louise and said, "Goodness, you know, if I can feel this difference, what difference is it going to give to our patients that are so unstable?" So our team consists of physiotherapists, and we're also lucky enough to have a physiotherapist who specialises in women's health, which is another area that's incredibly important in your hypermobiles. We have sports therapists, we have a podiatrist, we have an orthotist that comes, that's Merlin from DMO, a psychotherapist, a hydrotherapist, and we have our rehab team. So one of the plus things that occurred during COVID and the first lockdown was my husband, Tom Higo, set up our sister site, which is our rehab site, and it's known as Physiocure. It's just down the road from Physiocure here, and basically it's a bespoke rehab gym consisting of personal trainers and Pilates practitioners with all the latest equipment, state of the art. And what can happen is it's fantastic is it's one-to-one, so they can do one-to-one training and feel safe and secure in the knowledge that they're under proper rehab specialists. But not only that, what we are hoping to achieve over this our next goals, as it were, in our treatment and management of hypermobile spectrum disorder and hypermobile Ehlers Danlos is we want to start to set up and look into setting up classes for these individuals, bespoke tailor-made classes where they can all attend, they can liaise, the classes are with like-minded individuals, and also it makes it more affordable. Unfortunately, yeah, we are a private practice, but we are desperately trying to get more awareness out there and trying to get a bigger picture for healthcare professions so we can try and start to minimise these costs for the individuals. So we just have believed that a class would be a much better situation. I really wanted to get this slide in, and I've often talked about this, and my husband has been brilliant with me with this and has really brought our clinic on in many ways with how we treat our patients in general. Strength training is not all about the dumbbells. So when I say to my patients about going into a gym setting, I am not meaning that you're going to go and start to lift weights and start to do deadlifts and bench presses. We're talking about resistance training, which is so important, and more importantly, so we're talking about functional training. We're talking about just trying to get individuals back to a functioning state. And then often what you tend to find with your hypermobile Ehlers Danlos patients is that these patients have been told what they can't do. So basically what we've found by using a wide variety of strength training equipment, it exposes them to choice, it empowers them. The key is to finding what they feel comfortable using in what is an often very uncomfortable environment. So basically, work in partnership with your patients, agree and set person-centered goals. So why the MDT, and particularly why the MDT with your hypermobile Ehlers Danlos? Well, the World Health Organization defines rehabilitation as the use of all means aimed at reducing the impact of disabling and handicapping conditions and at enabling people with disabilities to achieve optimal social integration. Wagner, in 2000, defined a multidisciplinary team as a group of diverse clinicians who communicate with each other regularly about the care of a defined group of patients and participate in that care. Optimal social integration. We need to get these patients functioning and leading a functional life. Optimal social integration requires us looking holistically and therefore as a multidisciplinary team. Like the picture shows there, we're all clinicians fitting the pieces of a jigsaw together. So with the HEADS patient, we're looking at multi-systems. It's a multi-systemic condition. It has comorbidities, and these are the coexistence of two or more conditions in a patient. And a comorbidity is often associated with worse health outcomes. So we like to think of it as like tipping scales. You've got your musculoskeletal component, but then you've got these comorbidities: POTS, MCAS, gastrointestinal, fatigue, dysautonomia, psychological, bladder and bowel. You cannot possibly just treat one area without thinking of the complexities of the other areas, because they all have this interplay. One has a knock-on effect on the other. You know, you have to be careful with your exercise prescription. If someone's got POTS, you're going to have to be really, really careful how you get that person exercising. If they're going through a fatigue period, you've got to be really mindful of that. So we sort of talk about it like scales. They're always changing and tipping. There's interplay between all the other conditions. It's complex. One practitioner cannot possibly deal with this alone. Like I said, I just wanted to mention this with regards to surgeons because I think it's incredibly important. I think the more we can get these relationships as physios, the better for all of our patients. So we've achieved this close working relationship. If we feel any of our patients might be hypermobile spectrum, hypermobile Ehlers Danlos, we liaise and discuss because it can sometimes lead to poor surgical outcomes if they haven't been already detected. Surgery must and should be considered as a last resort. Patients have a higher risk of delayed healing, poor response to anaesthetics. Research has shown this. And at the moment, there's a lot of research going on and a lot of research is still required as to the conservative management. So physiotherapy. I'm sort of just wanting to show you what we look at as physiotherapists, because then you'll start to see how my brain and how often a lot of, we're workings as physios started to see this bigger link and how I could help these hypermobile patients as an MDT and the link into DM Orthotics. So as physios, we're treating pain that can be correlating with the hypermobility, frequency of subluxations, dislocations, soft tissue injury, past injuries. We're looking at proprioception, big one, decreased in hypermobile EDSs, and that can be due to many factors, but two of the hypotheses: increased joint movement, damaging the proprioceptive receptors, and also this sensation of pain in a joint. Muscle strength, so we're looking at strengthening workhorse stability, endurance training. We're looking also, you have to be mindful of the extra-articular, any organ consisting of collagen. You have to be really mindful of the fatigue, as I've just mentioned. And you've got to be aware of the psychological implications of this. Increased anxiety, depression, panic disorders, and they'll often have low self-esteem even in children and adolescents. And this is often due to years of being misunderstood and misdiagnosed. So with regards to exercising as physios, what we need to look into and be mindful of is you've got to start to look at the issues of fatigue. So pacing, boom and bust cycles, these individuals go through overexertion, leading to pain and fatigue and consequent underactivity. Keep it easy, simple, low effort at first. Proprioceptive training, loads of use of mirrors, biofeedback, the floor, contact with things, patient feedback at all times. I can't stress this enough. These patients know their bodies better than anybody, and not a one-size-fits-all for these individuals, and lots of strong foundations in each position before progressing. So already you can see from these two previous slides how we're already starting to look into the DM Orthotics. So we call it at Physiocure slow cooking. Why? Well, because gravity and complexity are an issue in the unstable. And Simmons et al. In 2016 found that pain, fatigue, fear of injury are common barriers to exercise. So if we use DMO Orthotics, unstable, well, we can give them some stability in the form of these dynamic orthoses. And if we can eliminate to a certain extent an element of pain, an element of fatigue, and an element of fear and caution, we can hopefully aim to achieve a more functional person. And so that positive cycle begins. But what you've also got to remember is, when we're treating the hypermobile Ehlers Danlos patient, it's not just about exercises. There are other modalities that we use. Education, reassurance, we're there all the time. I always say to my patients, you can contact me. Manual therapy, kinesiology tape, hydrotherapy, and relaxation. So like all patients, you need to care for them. Empathy, understanding, and compassion. So the examples now, let's have a little look at these examples. So this was a 14-year-old girl that had been told that she was quite mobile. She'd been referred to us by her orthopaedic surgeon with a snapping hip. So her orthopaedic surgeon wanted our opinion, as he did suspect an element of hypermobility. Over several months, eventually we did get her down to London, where this individual was diagnosed with hypermobile Ehlers Danlos syndrome. She also has had the comorbidities of MCAS, POTS, and other comorbidities. So this is what she came with. Okay, so after several months, I did sort of start to say that we also needed to start to work with DM Orthotics, sent it to Merlin, and the first port of call Merlin decided was the socks, just starting to get her a bit more stable right at the foundations, if you want to call it that. So this is her walking without the socks. And then you can visibly, once I play the next slide, you can actually visibly see the difference. And that's just with the socks. So between this patient and DM Orthotics, she's gone on and she's had basically full body done. So that was the first patient. The second patient came to see me with possible hypermobility. She'd been referred through the clinic as a recommendation, possible hypermobility spectrum disorder. I had a look, I assessed, and eventually she went down to London. We got her down there and she was diagnosed by Prof. Graham with hypermobile Ehlers Danlos syndrome, a CCI, POTS, and MCAS. So this is the individual walking without shorts. And then this is just with off-the-shelf shorts. I do believe that the patient is looking at DMO to go into custom-made shorts at some point, but you can already see the difference with just off-the-shelf shorts. Confidence, better gait. So she's already more confident like this. Imagine then what we can do with her confidence when exercising. Again, just remember, it is all about empowerment, getting these individuals feeling like they can achieve something. And then this patient also went for the shoulders off the shelf. So this was a shoulder movement, very hesitant, especially coming up overhead. You know, this is in her everyday daily activity as well. Imagine just reaching to try and go into a shelf, into the cupboards. Suddenly empowerment, as I like to call it, get her in the DMOs. Lovely. So I just wanted to include the slide. It's just signposting. These are fantastic charities. I'm sure you're all more than aware of them, but I just thought I'd put it on. And then in summary, don't be everything to everyone. Respect other professionals and recognise the complexity of the patient that stands in front of you. As clinicians, don't be afraid to ask for help and refer out to the appropriate professionals when needed. As the saying goes, Jack of all trades, master of none. Thank you.
Good evening, everyone. Thanks for joining us tonight. I'm Patricia McCotter. I'm the UK Clinical Manager with DM Orthotics, and also I'm an orthotist. So tonight we're going to be talking about joint working and how we really need to work together as teams to achieve the best clinical outcomes, especially for our EDS patients, our HADS and our HSD patients. And we're going to be talking about the story of how ourselves and Physiocure got together to try and achieve these outcomes. So also going to touch on the history of DM Orthotics, how the orthoses actually work, and how we design and make up the prescription of these orthoses, especially for our EDS patients. So as autonomous clinicians, that doesn't mean that we have to actually work in isolation. We all need to work together, and we've all got expertise in different fields. We've all seen different ways of treating patients, how we can improve our clinical outcomes, so we have to be able to share these so that we can all work together to achieve that best outcome that we can. So when we were in the ED conference over in Ghent a few years ago, we were lucky to meet Anna and Louise from Physiocure, and we found out at that stage we were a similar mindset about how we could actually work together and achieve good clinical outcomes for our EDS patients. So that's how it started, that relationship, and we've just been building that and improving the service that we're providing together. So it was back in 1994 when I qualified that I met Doreen, a physio that I used to do the clinic with. Now, Doreen had a wealth of experience and she taught me so much and influenced the way I practice even today. So Doreen used to always say to me that a body has to move, so we can't always make our orthoses rigid. So that stayed with me and held me in good stead for the other 27 years that I've been practicing. So we have to look at agreeing outcomes and goals and managing the expectations. These outcomes and goals have to be set with the patients and the therapist so that we know what we're all looking at, so that we know if we provide something, the therapist has to change their regime of treatment, or we need to treat theirs depending on what the therapist is doing. So we all need to work together, and we need to look at these expectations and goals that they are realistic. Sometimes we need to take things really slowly in the beginning, because we will be affecting the body part in alignment. So we have to wait until other body parts adjust to this new alignment. So it might not be instantaneous, but a lot of the times the effect we have is instantaneous. So we develop our services, and we continue to do so with our product development, our material development, and also the services we provide. So for instance, in Physiocure we started out with a few patients a month, and now we're having to increase our clinics there to meet the patient demand. Research is key to everything, and we're often asked about how our products work and how we can prove it. So we do have a hierarchy of evidence document that we can share with any clinicians, and also a compilation of research document as well that we can share. So if you want to forward your email address, if you would like us to send you that, then we can do. So how it all began back in the 60s, you can see this patient here, cerebral palsy, athetoid patient, and the physio has wrapped him in correct bandages. So you can just see the difference in his posture, his head position, his limb position, and just more engaging with that head, and it looks like a lot less effort to actually hold his position like that. So we couldn't continue to wrap all our patients in correct bandages, but it shows you the effect just of the compressional element. So when I qualified in 1994, I joined a company called Camp, and Martin Matthews was there working and developing the Dynamic Movement Orthoses at that time. So he was the lead on that project, and we were all then using the suits, and it was in the first instance cerebral palsy children. They had long arm, long leg suits. They were a nightmare to get on, they were a nightmare to change nappies, but we have progressed a lot since then and continuing to develop. So about 17 years ago now, the company we were still with, True Life, decided to sell up that part of the business. So Martin decided to buy that, and because his belief in the product, so continued with that, bought that part of the business, and has continued over the years to develop that into the company we are now. So our orthoses are either bespoke, custom made, or pre-sized. Our pre-sized product was developed after we had went to an ED Society conference over in Baltimore, and we had brought some samples over, and the reaction we were getting from the patients when we were there just blew us away, and we knew at that stage we had to develop a product that would be accessible to more patients so that they would be able to get this benefit. So all our products are flexible, there's no rigidity in them at all. They're polycotton based, so they can form well to the body, they're breathable, and then we add layers of reinforcement material to try and guide that body part and stabilise it. So it doesn't restrict any functional movement, but just holds the body in a better position. All our manufacturing is done down the south of England in Cornwall. So we work on computer-aided design and manufacture, but our patterns are still all cut out by hand, our fabric patterns, and then sewn up on the machines. So how does it work? This is where our research documents go into more detail, but we know that the compression helps with the sensory input, so that's the base material. So we take all the measures of the patients and then we reduce them all to get that compression. So that helps with sensory feedback and also helps with proprioceptive feedback, that awareness of where your body is in space. And that's what this patient group lacks, that proprioceptive feedback. So also our biomechanical positioning, so we're realigning the body parts as well. So we know that every motion, every movement is a result of a sensory input. So we've got a feed forward and a feedback loop going on all the time. So we know the better sensory input we get, the better motor control at the end of it. So that compression, that deep pressure, then helps improve this sensory input and then affects the motor output and that movement that we then have. We also look at biomechanical effects, so we know that our joints are affected by the structures that are around them. So if we've got muscle groups, so we know that we've got two muscles working together, so if one's weaker than the other, then the alignment and the pull of that joint is out. So we want to have a look at that and see where we need to improve that stability, or we need to add more pull to one side or another to try and stabilise and make that joint and the muscles work more effectively. So we have to look as well at the planes of movement. So we've got our sagittal plane, so that's our up and down movement, so our flexion extension motions. We've also got our coronal or frontal plane, which is the movements out to the side and in towards the body, so our abduction and adduction. And we've also got our transverse plane, which is all our rotational movements, so our supination and our pronation movements. So that could be in the arm or the leg foot position, so when we pronate our foot over, or our hips for internal external rotation as well. So we have to look at these and how we can change these positions. Also our support base, so either from the foot up, giving a good base of support, but also looking at the pelvic girdle and the shoulder girdle, so that we're given a good support there and stability there. So we know that given that proximal control helps with distal function, so we want to try and stabilise around these areas. And we also know that our centre of gravity and the forces working on our body are changing all the time, so we're having to correct that posture all the time to try and compensate for these movements. And also we have to look that, again, the body doesn't work in isolation similar to clinicians, so when we change one body part, it'll have a knock-on effect on the other. So if we realign the foot, the knee and the hip will change positions. So that's why I was saying that sometimes we need to take it slowly when we change our positions, so that the body can then compensate for this realignment. So this is not an exclusive list of where we use our products, but as I say, when we started out, it was cerebral palsy. I used to work in the adult neuro department as well, so I would say stroke patients and MS patients that we'd use the orthoses for. And I seen my first EDS patient about 25 years ago. It was the physio that brought them into clinic. We've got a new patient, but we don't know what to do with them. And at that stage, we made them a pair of socks, which was great and had a great effect on them for their stability from their base. So we continue to add to this list, and it always tends to be our therapist friends that come in and say, can you help out with this? And it's another new condition to add to our list. So So orthoses, as we say, can either be pre-sized or made to measure. Just a few of the pictures here that shows the kind of products that we produce. So they're all base fabric polycotton, so breathable, and then we layer up our specific reinforcements. And the good thing is they're machine washable, so we can stick them in the washing machine, dry them overnight, and they'll be ready to wear again. So how they actually work, as we say, this is through not only our research but patient feedback from our fellow clinicians and from parents or so that tell us this is the way these are working, and how we know they're working as well through research. But they're another tool in the toolbox, so we don't then say to the patient, well, you've got that, you don't have to be doing your therapy anymore. Everything has to work in combination with each other to get the best clinical outcomes. So when our patients come in to see us, usually they're asking us to manage maybe 1, 2 or mostly all of these things, so that reduction in pain. So we often see patients that are coming in pain and just trying to provide that stability and support to reduce that pain. With EDS, we've got a lot of fatigue, both mental and physical fatigue, just that managing that body and trying to keep control of every body part, just so exhausting. As we say, the stability, looking at the postural management and trying to manage these subluxations and dislocations as well. So our pre-sized products are not just a base layer, they've also got standard reinforcements to try and realign the body, but our bespoke products are made just for that patient, so we're looking at specific patient need. So our suits can be long sleeves, short sleeves, they can have toilet and holes, they can have zips so that they're easy to get on and off, or poppers or velcro, just to make it easy to get them on because they are really tight fitting. So we're looking at shoulder girdle control, pelvic girdle, and then we can look at the position of the hips, we can look at shoulder subluxations, and one thing that comes up in EDS a lot is scoliosis. So we do have a range of scoliosis suits that we work from our x-ray of the spine, and we'll add translation panels to try and guide that spine, try and give a bit of correction and slow down any progression of the scoliosis as well. So shorts and leggings, these are either bespoke or pre-sized. So again, looking at stability around the hip and looking at the hip posture. Do we need to externally rotate, internally rotate? We can look at the knees. We're trying to control that hyperextension of the knee, maybe varus or valgus position of the knee, and also things like patella migration. So just putting a bit of support in the stability to hold that patella in position. And we can have things again like zips or toilet and holes to make it easier to get them on and off. Our gloves or our gauntlets can be long sleeved or short sleeves. So here we're looking at our long sleeve, maybe looking at stability around the elbow to provide support so that we're not hyperextending, around the wrist to provide that support, around the base of the thumb. So if we stabilise around the base of the thumb, it makes it easier then for opposition and function with the fingers. We can have long fingers to prevent the hyperextension, or we can have them cut off with no fingers at all in them, and also for our supination, pronation control as well. Our shoulder stability orthoses can either be single or double shoulder as seen in the picture there, so male and female versions as well, and again pre-sized or bespoke. So you can see with the female version we've got a cut out at the front so that we're not putting direct pressure over the breast tissue. The other good thing about the shoulder orthoses is they go on frontwise, so you put your hands in first so that you're not having to bring that shoulder back to try and get something on, which is often the case in shoulder stability orthoses. So even doing that motion can cause then dislocation or subluxation trying to get your orthosis on, so this makes it a lot easier. And we can build things in like shoulder subluxation panels as well in the bespoke version. We often find as well that our patients like to wear these overnight within bed when they tend to dislocate in bed. This can hold and give them stability, and also our proprioceptive feedback. It also gives some pressure. They crisscross at the back, so we're giving some pressure over the scapula, which helps then with stabilising the shoulder so that function is easier. Our socks come with a dorsiflexion panel in the front, so that's to lift up the foot and the toes, so it helps with clearance when we swing through our leg. And we also can put in our eversion panels on the ankle and the foot, so to stabilise that foot when it's in stance, when it's on the ground, because often patients will say I go over on my ankle, so that's when we're trying to stabilise. It also gives a lot of proprioceptive feedback, so that awareness of where you're putting your foot. We done a study in Caledonian University a few years back when we looked at adults with learning disabilities and their falls during the day. So we'd taken some of the clients out of static rigid AFOs and put them into socks, and we found that their falling reduced dramatically, and it was because they knew then where they were putting their feet, so it worked really well. So all our reinforcements are designed for that patient need, although I said we have in our pre-sized versions some reinforcements that are already on there. But we've got about 71 reinforcements and we're continually changing. We're changing because patients are asking us, can we look at this? Therapists are asking us, could you do something to help with this? And that's why we're always changing and adapting. So all our reinforcements are patented designs, so nobody can copy the ones that we've got and ones we use. So we're changing and evolving all the time with different materials and different reinforcements, or so we're trying to mimic some of what you would have done with taping, and especially taping with EDS skin, that it's really difficult to get some tape that's kind to the skin, so we're trying to replicate that sort of support that you would have got from taping. So we'd like to thank you all for joining us this evening, and we'll continue to work with Physiocure to provide what we think is a great service for our EDS community. If you've got any questions, you can ask them and we'll try to get them answered. If we don't get them answered tonight, we will be doing a follow-up video just to try and answer the ones we didn't get to. So thanks again for everyone for joining us.
Hi, my name is Ashleigh Harley, and today I'm going to be talking to you a bit about my health journey and how the DMO Suit has dramatically altered my life, for the better of course. So I was diagnosed with a genetic condition, a genetic tissue disorder called Ehlers Danlos syndrome when I was 12 years old, which affects all of the collagen in the body. It comes in many different subtypes, as I'm sure you're aware. And in my case, I developed scoliosis of the spine and also a Chiari malformation in the lower segment of the brain, because I have a lot of instability of the spine and all the joints, which is very common in Ehlers Danlos syndrome, as we all know. So when I went about making my current film, because I am a filmmaker and we are currently making a film about Paralympic show jumping with an Oscar-winning team. The film is called The Dark Horse. If there is anybody watching who would like to become involved, then please do reach out to me. All you have to do is just look me up, and I would be delighted to hear ways you would like to become involved. We're always looking for more participants for the film. But we got in touch with DM Orthotics because to be able to make the film, I had to be able to ride horses again, and I'm pursuing my own ambitions to compete in para show jumping again. And at the time, I was just getting back into riding again, and I couldn't even stand up because my blood pressure was so low. And the instability of my joints meant that I was unable to walk at all. I was either on crutches or wheelchair bound. So it was actually my mum that initially approached DM Orthotics, explaining the situation, and they said, hey, the team in Redruth said, hey, come down and we'll have a talk, we'll see what we can do for you. And they created the DMO Suit for myself, and instantly I saw a huge difference in the quality of my life. Very quickly I was able to get back on a horse again. I was riding, my blood pressure was stable whilst riding and whilst show jumping, and my joints were stable, enough to be able to ride horses again and to pursue sports. Like many people, Ehlers Danlos syndrome affects my digestive system, my blood pressure. I have widespread pain, dislocations, subluxations, and I often need walking aids. And the DMO Suit helped dramatically. Obviously, it's not a cure because, as we know, there sadly isn't a cure for EDS yet. We can always have hope. But I would 100% recommend the DMO Suit to any fellow EDS sufferer or hypermobility sufferer, anyone who has scoliosis either, anyone who has hypermobility of the spine causing them a Chiari malformation, which is where the lower segment of the brain, what is the brain? The lower segment of the brain becomes segmented from the rest and begins pushing on the spinal cord, and it causes all kinds of coordination issues and stuff. I would recommend the DMO Suit dramatically because it will create a huge improvement of the quality of your life, and you will be able to pursue your ambitions, such as in my case where I'm making a film with an Oscar-winning team. It has been a dream come true. We've been working on the music, the films, and riding again. I've been riding a Grand Prix show jumping horse, which has been incredible, and it has just totally changed my life. And I will always be grateful to the team in Redruth who are doing life-changing work for Ehlers Danlos sufferers. They're lovely people. The technology they use is right at the frontier, so I have every good wish for you all, and I am so excited to see how DM Orthotics continues to evolve. And yeah, so if there's anybody out there who would like to watch the Dark Horse film, which is all about Ehlers Danlos syndrome and raising awareness of it, please do reach out to me, and also look out for it when it comes out too. So thank you again for having me. It's been an absolute pleasure. If there are any questions, do reach out to me. And I hope you've enjoyed the webinar. Thank you. Bye bye.